Good afternoon and welcome everyone. My name is Jesse Gutnick. I'm one of the bariatric and metabolic surgeons here at Cleveland Clinic, and I'm moderating the session this afternoon. We got a great panel. Jamie Sarver, who's one of the nurse coordinators in our department, but is also a patient, and she's going to be giving a patient's perspective. Karen Schulz is one of our obesity medicine specialists and also our overall program manager, myself, and Dr. Wilson, who is another one of our bariatric surgeons. During our time, there is a Q&A that you can feel free to submit questions to, which we'll answer at the end. And so as a question comes up throughout the content of the day, just send in a question. We're going to start off with Jamie's story. I'm going to talk a little bit about how weight loss surgery is effective. Dr. Wilson is going to speak about the safety of weight loss surgery. And Ms. Schultz is going to talk about what to expect from a practical aspect moving through a program. Then we'll move on to the Q&A. So just remember to send the questions to all panelists so that we can all see them, and I'll be able to see them at the end. With that, I'm going to hand things off to Jamie, if you can take things away.
Hi, thank you so much for joining us today. We really appreciate you guys coming. My story starts with me 5 years ago about working here and starting here and just learning about obesity and being at my heaviest weight during that time and knowing that I needed to do something about it. And I just happened to get put in the right place at the right time. So this is a picture of me in 2019 at my heaviest weight of 253 pounds. And then that was me a year after surgery in September of 2020. That surgeon is that's my surgeon, Dr. John Rodriguez. He's actually with Cleveland Clinic Abu Dhabi now, but he's still part of our team. Next slide. And then there's actually another picture of me with him in 2022. I kind of actually make it a little goal to continue every time I see him to get my picture with him, just so that I can update this webinar. All right, next slide. So here's a little bit about my particular case. Prior to bariatric surgery, at the time I was 34. My highest weight, like I said, was 253 pounds. I really didn't have any significant comorbid conditions. So those are things like hypertension, diabetes, sleep apnea. I really didn't have that. My biggest issues were PCOS, polycystic ovarian syndrome, as well as infertility. But my polycystic ovarian syndrome was pretty severe. And so that was something that was a big issue for me. I did have a family, and I do have a family history of obesity, more specifically on my maternal side. So my mother has suffered from obesity her entire life, as well as her mother. They both developed diabetes. So I knew that that was something that was potentially going to be coming for me in my future as I got older if I didn't do something about my weight. I also really saw my mom struggle like all of my life with her obesity. And so I knew what she was going through, just kind of secondary to seeing those types of changes that she struggled with. So for me, even more so of a reason that I didn't want to deal with that. I considered bariatric surgery prior to even working here. I knew that there was, bariatric surgery and that was an option that was out there, but it was just something kind of like in the distant. I didn't know how to actually attain that or how to even go about seeking that kind of thing, or if my insurance even covered it. But I had done diet and lifestyle interventions, and those really were not effective at helping me maintain. I would always lose a little bit of weight, and then it would come back somehow or another, or I would stop losing weight, and then I'd get frustrated, and, then this continuous pattern. So on December 13th of 2019, I decided I was going to for sure have surgery that day. So the day before surgery, you do go on a pre-op liquid diet. I was 233 pounds. So I had lost some weight from actually the pre-op liquid diet. And that's to help kind of shrink your liver and stuff like that before surgery. And then today, actually, my current weight is 125 pounds. So I've lost in the last 3 years about 128 pounds and been able to keep that weight off. My time in surgery was about 1 hour and 20 minutes. That's from the time that I actually got wheeled into the actual operating room and then them wheeling me back out. My total time in the hospital was 1.5 days. It took about 3 days worth of me like really being like, I just had bariatric surgery. I'm having surgical pain, that like abdominal pain where you're really making sure that you're taking your medications and staying ahead of the pain. That was really about 3 days. And then after that, it was just kind of like Tylenol as needed. And usually I only needed the Tylenol, like if I had been up and on my feet and moving around for a good chunk of the time, then I kind of felt that like weakness and tiredness and, you know, just kind of general achiness. I was up and moving and walking pretty well within 3 days. I was actually the house that I was living in at the time. There was 4 different flights of stairs, and my room was all the way up at the very top. And so I had to at least walk down two flights just to even go to the bathroom, and then 4 just to be able to get out of the house. So I definitely was able to walk up and down stairs and move around pretty well. You just have to be careful for the bending, pulling, pushing, those types of things. And then I was back to work in about 4 weeks, and I really didn't have any problems going right back to work. Some people have you know, a job that is a little more sedentary and they can go back after a shorter amount of time. But really that's a discussion to have with your surgeon. But I had the gastric bypass also. I wanted to make sure I said that in 2019. So next slide. So I wanted to just kind of show this. This is my weight graph over the course of 5 years of being here. So you can kind of see my weight was fluctuating very minimally before surgery. It went down a little bit and then it kind of came back up to my highest weight of that 253 pounds. And then you see right at that surgery mark that I was about 233 pounds. And then at 6 months, that's when I had lost, you know, the most rapid amount of weight loss. And then at 1 year and 2 years post-op, you can kind of see where my weight is pretty evenly staying at the same weight. And I've been able to just kind of maintain that weight loss. Next slide. So I like to talk about some post-op milestones that are just important, that were important for me, that I recognized and I share with a lot of people. So at 2 to 4 weeks post-op, really the liquid diet is still pretty much your only nutrition source. You're not really eating at even at 2 weeks post-op, you're not really eating much food. You can kind of start eating some softer foods starting like 3 to 4 weeks. But it's kind of boring. So you're kind of sick of protein shakes by this point. And then you're still working, you're actually really working to reach at least one of your protein or water goals. You are given those when you meet with a dietitian. They'll talk about just how much water you should be trying to get so you don't get dehydrated, and how much protein your body specifically needs. There's a calculation for that. So it's important to try to work towards getting those goals. And then also getting moving during this time is actually really important. And for me, I was off for 4 weeks. So I actually kind of took that time to like get in the habit of making a new routine for myself and just focusing on like, I need to make sure I'm drinking water. I need to make sure I'm taking my vitamins. I'm, you know, getting that routine established while I had time to kind of figure that out for myself. And then my surgical pain during that time, it's at a minimum. You're not really having too much pain other than, like I said, the bending, pulling, pushing kind of thing. At 1 to 3 months post-op, you're really actually able to hit your protein and water goals on a daily basis. Your weight loss is noticeable to you as well as to others. Like every day, essentially, you would have somebody that just saw you the day before and they're like, oh my gosh, your face is completely different from when I saw you yesterday. So it's becoming very noticeable, but you're in that rapid weight loss period. And then another thing that's noticeable at this time is that your activity level is already starting to increase. Prior to surgery, I worked on the floor and worked as a nurse. So I remember coming home and my feet would be so sore from being up all day long and just being on my feet. literally starting like right when I started coming back to work at 4 weeks post-op, I noticed immediately that I was not having any foot pain, things like that, joint pain. It was already changing. At 3 to 6 months post-op, this is when I say food is finally your friend again. You are able to kind of start eating a little bit more. You have a little bit more of, you don't have to rely as much on those protein shakes. So it's kind of like nice to have a little bit more variety in your diet again, and just kind of being able to just enjoy food, even in the small amounts that you're taking in. You're still losing weight at a really good pace here. It's important to just make sure that you are keeping up on your exercising and, you know, eating the way that you're supposed to during this time, just so that you're not developing those habits that can kind of get you in problems later on. And then again, your activity level, even at this point, I was 6 months post-op during the summer, and I was out in my yard gardening, building fences, doing things that like I just never would have been able to do, or it would have taken me forever to be able to do prior to surgery. I could immediately tell a difference. At 6 to 12 months post-op, the most amount of my weight loss was achieved by this point. But it was starting to slow down. I could tell that it was starting to slow down as I was getting a little bit further post-op. You're hitting your protein and your water goals daily. If you're not doing it, if you're not getting them, then it's usually just kind of behavioral, or, you know, I forgot to get my water in today, or I got busy, those types of things. So it's, like I say, still more really important to continue to focus on those and establish a pattern daily, just so that you can continue to hit your protein and water goals. One thing I noticed here as well is I have minimal cravings for things. So this was really brought to my attention when I was at 6 months post-op, and my son's birthday is right almost exactly 6 months post-op. It was in June, and we literally threw out like half of his birthday cake because nobody ate it. We had a party and everything, but we had half of this birthday cake left, and it sat there for a week and it went bad. And I realized, oh my gosh, like I was not thinking about like, oh, I have cake here, I'm just going to eat that. That didn't even come to my mind. I didn't even crave it. I didn't have a desire for it. I had one small piece during my son's birthday, and I didn't have any more after that. And still to this day, I really don't have cravings. Like I can see food or see treats or snacks and things like that, and I don't necessarily have a desire for it. It's pretty rare that I need to have a sweet or something like that. At this point, you're also really comfortable with your anatomical changes in your body. So you kind of know how you're going to react to like food. If you eat something that maybe doesn't agree with you, or you ate too much, you at this point know those changes, and you're eating kind of like at a normal level, just a smaller amount. And then you have a lot of changes in your confidence and your intimacy and your relationships at this point as well. Definitely with my husband, he was supportive of me having surgery, but he didn't feel that I really needed it. But then afterwards, and him realizing how much better I felt, he was just blown away. And I mean, there were times where we wouldn't see, this was during COVID, so we were really not seeing many people, and we would see somebody at the store or something like that, and he'd be like, look at her, doesn't she look great? Doesn't she look great? Look how much weight she's lost. And so for me, that was actually kind of nice, like knowing like in the end, my husband was actually okay with it. And he, you know, finally came around and got on board with me having surgery. At this time too, you really see those non-measurable goals. I always say like you can put a sock on while standing, but that is one thing that I noticed right away is like my balance even improved on things that like I can stand on one foot again and not worry that I'm going to fall. Those types of things are things that you can't really measure it, but you just kind of all of a sudden will notice like I couldn't do this before and now I can. So it's kind of a cool feeling. So next slide. So in December of 2020, that's about 1 year post-op. And then I like to talk about how do I maintain that? Because now I'm in that like 3 years post-operative kind of phase. So some of the things that I still am mindful of I still look at how much sugar I'm taking in every single thing that I eat. I try to make sure that there's not more than like 11 grams of sugar in anything that I put in my mouth, just because I know that how my body will react to it, and it can make me a little bit sick. And so I try to make sure I avoid that. I'm still mindful of making sure I'm getting my protein and my water intake daily. Usually I do have to rely on a protein shake or a protein bar pretty regularly, just to make sure that I'm hitting those protein goals. Exercise, we talk about this a lot in our program and how important it is to exercise. And I will admit, I'm the first person that will admit that I kind of rode that like, oh my gosh, I'm losing weight, I don't need to exercise kind of thing. But starting at about 6 months, when I started noticing my weight was starting to slow down and I was still doing all these other things and I felt like I was active. I was out in my yard building fences and doing all kinds of yard work and just heavy activity. That way I was noticing like I'm still not losing any weight. Why am I slowing down? And so then I decided I'm going to start incorporating exercising. And the next slide I'll show you, you'll see why I say exercise is so important. And if you can start it right away, start it as soon as you can. And then also just continuing a daily vitamin regimen. That's super important. You want to make sure that you're taking your vitamins. There's bariatric, like post-op surgical vitamins that you can get. Those are usually the easiest ones because they have like a 1 a day one that you can take. And I was taking vitamins beforehand. So I just, it's important to continue them. Also, keeping up with your post-operative appointments is really important. I actually work with the medicine team. And so a lot of the patients that we tend to see back that have had some weight regain after surgery and they come back to us, a lot of times they've kind of fallen off the wagon a little bit, and it's been several years since they were seen. And sometimes we get patients that I was just too embarrassed to come back. I started gaining weight and I didn't know what to do, those types of things. But keeping those post-op appointments, that's how you can kind of catch, if you're struggling or if you're starting to notice that you're not losing any more weight, or if you're starting to notice that you did lose weight. Those are things that we can help you work through at that visit, as opposed to waiting a couple years and coming back to us and you're ashamed of, your weight progress. And we don't want you to feel like that. So keeping those appointments is really necessary. Next slide. So this is why I like to talk about exercising and cardio and just weight training in general. I don't go to a gym. I don't have a gym. I just have a home fitness. I have free weights and I have a rower. And so in summer of 2020, that was about 6 months post-op. I was about 165 to 170 pounds. That's when I started noticing my weight really wasn't changing. And even in the summer of 2021, you can see I didn't really lose a ton more weight, but that tone and that muscle, that was like immediate. Like you could see that right away. And that was actually one of the first times in my life where I really noticed like, oh my gosh, me actually exercising is actually doing something for me. I can see that I have abs now, I can see my arm muscles, which before that was one of the most difficult things with trying to exercise and, eat right, all of those types of things. You just didn't really see it before surgery. And then after surgery, it was just immediately I was able to see those changes and those results. So I always make sure I tell people exercise is so important after surgery, and the sooner you can do it, the better. I think that's it, Dr. Gutnick. Yep. So thank you so much for joining us today, and please feel free to ask me any questions or anything in the Q&A.
Thank you so much. And I'm going to move on to you saw an example of how it worked well in one person, but I'm going to talk a little bit about the science behind why bariatric surgery works. So basically, your body is designed to maintain your current weight. And one way to think about that is like a thermostat in your house. So if it gets cold outside, your thermostat triggers the heat to go up, and it brings the heat in your house back up. Likewise, if it starts getting hot outside, you turn on your air conditioner and it comes back down. And so you have generally a weight thermostat. And that's why even while some people are very successful losing weight over the short term, typically you regain to where you were before. And we think of that almost working like a thermostat, but instead of the heating and cooling elements, it's the hormonal balances in your body that cause this to happen. So, and essentially, when you're dieting, your body fights weight loss, and weight loss surgery reprograms how your body manages food, both over the medium to short term and over the long term. And that effect is strongest in the beginning, but then is maintained over time as well. So, if you look at the hormonal levels in your body when you're dieting, the first thing that goes down is something called your basal energy expenditure. That's how much energy, how many calories your body uses just if I are sitting, not doing anything in particular. And when you eat less when you're dieting, that goes down as a mechanism to compensate. After bariatric surgery, the amount of energy that you use just living goes up, and that elevation and that lasts for quite some time, and depending on the person, it can last over a very long period of time. Similarly, when you're dieting, your sense of appetite is increased. After surgery, it's decreased. The sense of fullness, of course, goes down with dieting, goes up after surgery. The stress response hormones, which are elevated by obesity, go down with bariatric surgery. And then certain gut hormones, such as ghrelin, GLP-1, peptide YY, go in the opposite direction. And these are the hormones that are important for how your body is taking the energy and the nutrients that you eat and how it uses it in your body and how it distributes it, whether it's storing it, burning those to increase that basal energy expenditure. The most common options are gastric bypass and sleeve gastrectomy. They make up probably around 90% of the weight loss operations that are done. And then there's some less common ones, the duodenal switch surgery, which is a little bit more powerful than gastric bypass, and then revisional surgery. That's either for somebody who may want to either enhance their weight gain, or enhance their weight loss, or had some weight gain, or sometimes can be corrective. So some of the patients that might be signed on may have a history of bariatric surgery and had some problem they are looking to have corrected or helped, or a symptom that they may have that needs to be helped. And that would be either duodenal switch surgery or revisional surgery. But I'm going to focus in terms of the scientific side of things on the gastric bypass and the sleeve, because those are the most commonly performed operations. One of the most seminal studies, and it's almost even a little bit old now, in 2017, was performed here in the Cleveland Clinic. And this was looking at patients that had diabetes with their obesity and was looking at weight loss, but in particular was also looking at how these surgeries treated diabetes compared to the best medical treatment of diabetes. Because not only is it weight loss surgery, but it's also what we call metabolic surgery and treating these other health issues. And first, we're going to look at weight because everything kind of tracks along with that. This graph shows three groups. So the first group is people that had the best medical therapy. So this was intensive visits with the endocrinologist and treatment for their diabetes. And they're represented in yellow. And the up and down part of the graph is the patient's BMI, which is a ratio of your height and weight. And it's a rough estimate of your degree of obesity. And then along the long axis, that's how many months following when they were enrolled in this randomized trial. This one goes all the way up to 60 months. And the other two groups are the gastric bypass in orange and the sleeve gastrectomy in blue. And so you can see, actually, the people with the best medical therapy did lose some weight. And they did maintain it to some degree out to the 60 months. But you can compare it to the gastric bypass, which was slightly more powerful than the sleeve, and approximately 10 BMI point reduction after these weight loss operations. Similarly, and this is what study was really geared to show, was comparing the change in the A1C, or how well these operations were treating the diabetes. And you can see about 6 months after what's called randomization, where people were randomly assigned to the medical treatment or the surgery. They were the medical patients did have a really good improvement in their A1C, which is about 1.5 points, which is quite good actually. And then that slowly came up over time. With the gastric bypass and the sleeve, those were down in the range of around 3 A1C points, which is quite significant. So similar to that study, and the reason I showed that study is it's one of our few really well-run randomized control trials, which is sort of the highest level. We see the same effects in all of the other areas of that are related to obesity. Some very common ones are sleep apnea, fatty liver disease, joint pains, etc. All of these improve with the weight loss surgeries, and they improve over the similar time frame that you saw there for diabetes. And so the whole goal is hopefully we're preventing these other health issues if someone doesn't already have them, but stabilizing and reversing them if you do. And with that, I'm going to hand off to Dr. Wilson, who's going to talk about the safety profile for surgery.
Hello, everyone. It's a pleasure to just talk with you, and I'm glad you've been able to attend this webinar. So again, I'm Rickesha Wilson. I'm also one of the weight loss surgeons here at Cleveland Clinic. And I just want to talk a bit about the safety of weight loss surgery. Of course, this is one of the most important things that people want to know when they're exploring their options, because of course you want to be healthier, but not at the risk of safety. Next slide. So there are multiple factors to consider when we talk about safety and how we measure safety. And, one way is, in a lot of our studies, we compare weight loss surgery to usual care or non-surgical methods to treat obesity or follow patients with obesity and other related conditions. And we'll go over some of those studies in the following slides. But what the two components that are really important to consider and the take-home points are: the risk of surgery is small and the health benefit over time is really large. Next slide. So in this study, in this graph, it illustrates several different procedures. This is a graph of about 67,000 people with diabetes, and they've undergone a myriad of different procedures. And so we compare the safety and the outcomes of the bypass, for example, which is at the bottom of the screen. So 3.4%. This is the percentages are the complication rate. And so if you compare that starting from the top to open heart surgery or bypass surgery, complication rate is near 50%. Going down a little further, maybe you've had a knee procedure, that risk of complication 16%. Going down a little further, maybe some of you have had your appendix out or gallbladder out, 3 to 4% risk of complications. So the bypass is very safe and very comparable to a procedure like a hysterectomy or getting your gallbladder removed, which is important to consider. Next slide. And so safety over time. So this graph illustrates mortality. And of course, people don't necessarily ask about it, but you should know from the early 2000s, close to when we first started doing these weight loss procedures with small incisions, to more recent years, the incidence of death from this surgery has gotten lower and lower each year. And so out of 1,000 cases, maybe 4 in 1,000 deaths may have occurred in the early 2000s. And by 2009, 0.6 deaths out of 1,000 deaths. So that percentage is very low, and it's even lower now in 2023. This graph doesn't show it, but that trend continues to go down. So the risk of death is very low, and that just also speaks to the safety of weight loss surgery. Next slide. This is a study evaluating patients with obesity who underwent weight loss surgery, about 2,000 patients compared to about 11,000 patients with obesity who did not undergo weight loss surgery. And these people also had type 2 diabetes. And we looked at the major adverse cardiovascular events, that's stroke, heart attack, abnormal heart rhythms, kidney failure. So multiple disease processes related to poor cardiac outcomes. And so for this study, we found that patients with obesity and diabetes who underwent weight loss surgery in the long term reduced their risk for adverse cardiac outcomes by about 40%. And so that's the power and the difference over the long term when we say there's a low risk of surgery and a large health benefit over the long term. Next slide. And this is another slide from that study. As you can see, the bottom axis is going up in years, and the y-axis, or the vertical axis, is the incidence of adverse cardiovascular events such as heart failure, arrhythmia, stroke, high blood pressure, kidney disease, coronary artery disease. And you can see the incidence is higher in the patient population who did not undergo surgery over the 8 to 10 years compared to those who had weight loss surgery. And of course, their obesity improves and their diabetes improves. And so some of these other medical conditions that predispose you to adverse cardiac events in the long term are improved after weight loss surgery if you have obesity. Next slide. And so how do you prolong your life and then improve your quality of life also? So research overall shows that treating obesity effectively, and the most effective treatment is weight loss surgery, can add 6 years to your life. And if you have diabetes, it can actually add 9 years to your life, because obesity and overweight is the second leading cause of a lot of medical conditions and adverse outcomes of health in the country, behind tobacco. And so obesity is related to diabetes. That can be a leading complication to getting amputations or people being on dialysis. So the way you get longer life is that treating the obesity actually helps improve or treat the other medical conditions that come along with it or might be related to it. So your sleep apnea improves. You treating your diabetes and your overall quality of life improves. Your likelihood of getting a heart attack or developing a stroke decreases when some of these other medical conditions gets better. We just published a study that was in the New York Times and Washington Post and a lot of media outlets about how significant weight loss after weight loss surgery actually lowers your risk of developing cancers that are related to obesity in the long term. And there's a 32% lower risk of developing obesity-related cancers after weight loss surgery compared to those with obesity who don't get their obesity treated with weight loss surgery. Treatment of fatty liver disease, it can improve the safety of childbearing and more. So this is how you get longer life, because overall your health is improved, and the things that you were at risk for, that risk lowers over time when you've had a significant weight loss. And again, our research shows that weight loss surgery is one of the most powerful tools that you can have. Next slide. Even with the COVID-19 pandemic, and we were able to learn so much through a tragedy like that. We were able to study individuals who had obesity and a history of weight loss surgery or not, and to study the severity and the impact of the COVID-19 virus and pandemic on their outcomes. And so we compare patients who tested positive for COVID and then compared their outcomes. You know, did they need to be admitted to the hospital? Did they require admission into the intensive care unit? Did they need to be on artificial ventilation? These things are important. What was the death rate? And our next slide kind of just shows some of those outcomes. You can go to the next slide. Yeah, so hospital admissions. So if you can see, if we match some of these patients with some of these comorbidities, those without surgery are in red, and those who underwent surgery previously for obesity are in green. The admissions to the hospital were much lower, more than half. ICU, intensive care unit admissions, needing to be on a ventilator, dialysis, death. So the severity of the impact of the COVID-19 infection, those patients who underwent weight loss surgery were much more protected because of the health benefits overall, which is important. Next slide. And thank you for your time. That's all I have. I'll hand it to my colleague, Karen Schulz, one of our nurse practitioners.
Thank you, Dr. Wilson. Hello, everybody. Congratulations to all of you for taking this next step and learning more about bariatric surgery, how it can change your life. I'm one of the advanced practice providers here at the Bariatric and Metabolic Institute. I see patients pre and post-op. I'm also the program manager. I'll talk a little bit about actually becoming a patient in the program. And I'm sure as a new candidate, you know, you might be feeling a little apprehension, have a lot of questions. So I do want to reassure you that we do have a team here that's going to help you to navigate to your goals. Next slide. So navigation is actually something that we do for you. Each patient has their own patient navigator. And I'm going to skip to this slide because I think that might be in a different order. We'll come back to the navigator, but we are located at several area hospitals close to home. So you have regional access, 3 centers of excellence at main campus, at Fairview Hospital, at Hillcrest. We also do 90% of our visits can be virtual if you want to do it in the convenience of your own home. Next slide, please. All right, you have lots of great choices, we know, in Cleveland for bariatric surgery programs. Some of the things that make us unique here, we're not only the largest program in the state of Ohio, but we also have some pretty big distinctions. We are #1 in Ohio, located in the Digestive Disease and Surgery Institute, so bariatric surgeries in that #1 slot. In main campus is #1 in Ohio. This is by the U.S. News and World Report assessment. Fairview Hospital, #5, and Hillcrest is rated #4. Next slide. Okay, so now we get to the navigation part of it. As you come into the program, so one of the very first steps is for us to assign you a navigator who will check to see if you have insurance benefits. Okay, so we want to make sure that you're coming in with eyes wide open as far as, do you have coverage? What does that coverage look like? What does your insurance company require? We'll also make sure we coordinate appointments, ensure a timely workup, and at the end of the preoperative preparation program, the navigator will take everything, put it together, send it to your insurance company, and get it approved before we schedule that surgery. So there'll be no financial concerns. We'll make sure we get that coverage for you. If you do not have coverage, a lot of people ask this question, we do have self-pay options, which we hope you wouldn't need, but if you do, we can talk to you about that at a later time. Next slide. So being the largest program in the state of Ohio doesn't mean that we don't provide personalized service. So each of our patients come in and they have a team. A team consists of a base of 5 people. The navigator, we talked about, a bariatric registered dietitian who's going to meet with you at least twice, more if needed, to teach you everything you need to know about eating before and after surgery, so you'll feel completely comfortable with the program and how you're going to eat. There's an obesity medicine provider. Some of you may see me. We also have 7 other providers, and their job is to make sure that surgery is as safe as possible. So one of the ways we provide that excellent safety profile is to do a complete assessment. We work in conjunction with your primary care doctor if you have one, or your specialist if you have one, but you don't have to have those individuals to come into the program. We will do the assessment and make sure you are absolutely as healthy as possible before undergoing the surgery. Everyone will also have their own psychologist who will make sure that you're emotionally and psychologically prepared for anything you may encounter. We know that people eat food for lots of different reasons, and we want to make sure that the coping mechanisms that you may or may not need after surgery are solidly in place. Of course, everyone has their bariatric surgeon, and then any consultants that you need are available here at the Cleveland Clinic. If you have your own consultants in your hometown, we can also work with them. Next slide, please. So in summary today, how does bariatric surgery work? We know, as Dr. Gutnick said, severe obesity is a metabolic disease. Your thermostat is stuck. I know many of you have been able to lose weight before, but it's really the keeping it off part that is so difficult, and that's where bariatric surgery is a powerful tool to help you to keep that lost weight off. Calorie needs are low in this metabolic disease, body set point is high, and of course, as I mentioned, short-term results of dieting make it very difficult for our patients without surgery. So surgery combined with healthy diet, physical activity is currently the only consistently and sustainable way to keep weight off for a lifetime. So thank you. I think we're going to bring the panel back for our Q&A.
Yeah, thank you so much. We've got a few questions in already, and please keep sending the questions in. And if all of our moderators or all of our panel could turn on their camera and audio, we'll get started. Remember, you just submit them to all panelists so we all can see them. So I'm going to start off with Jamie. The first question sent in was for you. Jamie, you had this person was very impressed by your weight loss, and congratulations. And she asked, did you have any loose skin, and how did you avoid that or fix that?
So I kind of am fortunate. I don't have really any loose skin. I mean, I have, the grandma, little bit of that from needing to exercise a little bit more recently, but I don't have any loose or hanging skin. My BMI was at like 45, I think was my highest BMI. So I was right in that kind of range where I really didn't have to worry about that. I just made sure that I was exercising, and the weight resistance training really did help with that, to make sure that my skin, like the muscles and the skin, didn't really have too much sagging or hanging skin.
Yeah, if I could add a little bit to that's something that depends on from person to person. It's unusual that people undergo skin removal surgery or things like this. If you are somebody who does end up needing that or wanting that, we have excellent plastic surgeons we can refer you to. There's also, as Jamie is a great example of, exercise that can significantly minimize that, both loose skin and then also some of the loose muscles that have to, like for example, your stomach muscles that used to accommodate more fat on the inside of your stomach can be strengthened and then sort of tighten up that area too. So while there are some people that need to pursue that or want to pursue that, the majority of people don't need to. Here's a question to Karen Schulz. My insurance does not cover surgical weight loss. Do you guys also do non-surgical weight loss within your program? Or if not, how do I move forward?
Yes, we one of the things that's really great about our program is we don't just offer surgery. We have a medical weight loss program as well. So that would normally be covered by insurance, and you can find out about that on our website. you can also call Cleveland Clinic Scheduling, and we work with medication therapy. I think that to be realistic, medication therapy is usually good for maybe a top of 10 to 15% of total body weight loss, which is why surgery really comes in so nicely for people with severe obesity. We also encourage people to talk to your employer. There's lots of data out there to say that covering weight loss surgery actually saves employers money because we know that you will have less health problems over time. So that's an option too as well. Or looking for another insurance potentially that covers weight loss surgery.
And I think we also have self-pay options, which are there for you to consider if you are interested in weight loss surgery because of the amount of weight that you feel you need to lose to be healthy, even if you don't have coverage. So there's also options from that perspective. This is a question to Dr. Wilson. I had a liver transplant 5 years ago due to NASH, but I still have obesity. Would I be able to have bariatric surgery?
So certainly you could, and I think you certainly would be reasonable to join our program or pursue weight loss surgery. So and going back to kind of talking about safety, for every patient, we review your medical conditions and your prior surgeries, because in particular, we want to make sure you're healthy and fit enough for surgery. But having a liver transplant is a huge undertaking. So if you can make it through that, you certainly could make it through weight loss surgery, but we certainly would have to consider the changes on the inside of your body that would impact how your surgery went. And so I certainly think you could be a candidate. It's been done in patients with prior transplants, liver included. And so we would certainly just do an extensive evaluation of your history, your prior operations, how that went, what your needs are. But certainly if you've had a prior transplant, including liver, you are still a candidate to be evaluated for weight loss surgery.
Yeah, and I think that goes for any prior surgical history. It may potentially change the operation we choose to make sure that it fits with your prior history. But in particular with the transplant, working with your transplant doctors to make sure that they know what's going on and are in the loop, so they can take care of your liver over time, or whatever organ. I'm going to answer this one quickly. Does this apply to Cleveland Clinic and Weston? In general terms, it does, in that the science that we talked about is true for bariatric surgery in general. They're not in the same exact program, but if you are a Floridian, they're certainly a good option to connect with. Dr. Wilson, so kind of piggybacking off of, maybe one of the more complex prior histories, which would be a transplant history, to really any kind of history, how do you determine which surgery is right for each individual patient?
Yeah, that's a great question. So we consider a number of things: your medical conditions, prior surgeries, what your actual weight loss desires and goals are. And then we have a discussion during your appointment, especially with a surgeon. We'll talk about each procedure and go as in depth as we need to during your appointment to make sure you understand what happens in each procedure, and also understand some of the risks associated with each procedure, short-term and long-term. And so some medical conditions you may have, like severe reflux or heartburn, may lead us or guide us toward the bypass over the sleeve, for example, because it could potentially worsen reflux. Not in every case, but in some cases, depending on the severity. So that's just an example. So it depends on what your desires are, what we feel is safest, and we have a discussion. You may determine that the weight loss that you would likely acquire with one procedure may be more than what you're looking for. And so we might go with a different procedure, even though you may be safe for both procedures. So it's really a conversation between you and the surgeon ultimately. And we, after educating you and answering your questions, we are able to come to an agreement on the best procedure for you. And excluding the medical testing that you may undergo to give us more information.
Piggybacking off of that, there's another question that said, excuse me, was asking, saying I have a BMI that's on the higher side in the 80s. Is there a particular operation that you would recommend for me, Dr. Wilson?
Yeah, that's a great question. So if your BMI is in the 80s, you certainly need a powerful tool, and different procedures kind of offer a different power or benefit. But oftentimes we may start with one procedure like the sleeve to get your weight down a bit lower before we do maybe a second stage procedure in some instances if we're able to. Such as one of our more powerful procedures, actually two, are the duodenal switch or the SADI procedure. And that's where we kind of combine the sleeve gastrectomy as well as a component of the bypass. So we're kind of doing two things during those procedures. But sometimes we'll do the sleeve first so an individual can lose a significant amount of weight. And that may make it easier for us to do the second bypass portion of those procedures once you lose more weight, because the higher weight, sometimes it may make it more difficult for us to do complex things during these procedures. But with high BMIs, it's certainly a discussion that we could have during your visit with the surgeon. But it's not only surgery. We have colleagues that can prescribe weight loss medications to facilitate more weight loss. And so we can really offer a combined approach, not just with the surgeries that we can offer, but also medications and lifestyle adjustments to really maximize your weight loss and give you what you need.
Thank you. Jamie, I know you went over it a little bit, but a couple of people have asked, what does the typical recovery look like, and when can you get back to work?
So yeah, I specifically was out of work for 4 weeks. So each patient is going to be very, patient specific. That's another conversation that you'll have with your surgeon. And it kind of depends on what your job actually really is. If it's something that's pretty physical and demands a lot of lifting or things like that, you may need to be out for a little bit longer or find some way of doing more of like a light duty type role. If you're sedentary and you're kind of just working in an office and you don't really have to worry too much about, moving or hauling of anything, then you're probably okay to go back at about 2 weeks post-op. But again, that's going to be something that you're going to discuss with your surgeon. And when they write those FMLA paperwork or forms for, work excuse, those are going to be those conversations. And then it also kind of depends on how you're doing after surgery. You have a 1 month post-op appointment. And so sometimes if you're struggling or you're having a hard time, with nausea or things like that, sometimes those things can be extended where you're maybe not quite ready to go back to work right at that 4 weeks. And then you have that post-op appointment and your provider can give you, some longer time off or if you need it.
Thanks.
Mm-hmm.
I'll take the next one quickly. Is there an interpreter at the hospital? And the answer is absolutely. There's always interpretation services. These are actually required by law for hospitals to provide. And so depending on the language, there may be an in-person interpreter or a over the phone or a video interpreter at your meetings. Also, depending on the language that you speak, several of our surgeons speak fluent Spanish, which is probably the most common other language besides English, which is certainly not the only one that we're happy to take care of. Karen, there were several practical questions that I'm going to try to kind of roll into one because they're all along the same lines. From when someone starts a program, assuming that they have quote unquote typical insurance, what kind of time frame are they looking at from first visit to surgery?
Yeah, that's probably one of the more commonly asked questions. And a little bit of that depends on if your insurance company has any pre-surgery medical weight loss requirements. So for instance, just to throw out an insurance, CareSource has 6 months of required pre-surgery medically supervised nutrition visits. So we can do those here in the program, but generally then your program would last for that 6 months. During that time, you would see the surgeon, you'd see the dietitian once a month, you'd see obesity medicine, you'd see a psychologist, but you would be 6 months in our program, providing you attended all your visits, would be sort of on average for that person. But you can come in. Some insurance companies don't have a nutrition requirement. If you don't have a lot of health issues, we've seen people get from the seminar to the surgery in 3 months. That's less common, but it's possible, and we try to work with you if that's your priority time to surgery. We'll do everything we can to try to get you in for all those visits without, of course, compromising safety, making sure all your health issues are in good order, and making sure that we feel that you are completely prepared before undergoing the operation.
Thanks. And then, to wrap into that, what are the next steps, which I will also conveniently have up on our on the slide here, because several people asked, what is the next step after this seminar, Karen?
Yeah, so if you haven't gone to clevelandclinicweightloss.com, you can also go to the Cleveland Clinic website and click on the next step to view an educational seminar. And that is not the same thing as the webinar. It's a little bit more of what it's actually like to be a patient in the program. There are several patient testimonials. And then afterwards, there's a registration questionnaire. So you registered for the program at that point. And at that point, the navigation team will check your insurance. And then 2 things will happen. If you do not have benefits for bariatric surgery, they're going to send you an email. There's a few people on the call that haven't heard back, so please check your email, because there may be some information there about how to contact our financial counsel for self-pay options. If you do have coverage, then one of our schedules will reach out and ask if you would like to start scheduling your appointments. And the 4 core appointments are the surgeon, psychology, nutrition, and obesity medicine, and then additional visits as your insurance requires. Yeah, that's basically it. The navigator will send you a welcome email that details the insurance requirements.
Thanks. I'm going to take the next one. So there was another transplant related question, although this person was very altruistic and was a kidney donor. Congratulations to you, and thank you for doing that. Would that person still be eligible? And the answer is yes. In short, yes. We might change the operation we pick for you depending on how your health is overall, and that's really what we go over when we have our initial consult with the surgeon, is figuring out, well, what is your health history that's relevant to these procedures, and how does that affect what we recommend? And then certainly, at least the way I counsel patients, is I go over what I'd recommend based on your history, and then educate you about how they're different, what the trade-offs are between them, so that you can pick the one that's the best fit for you. Dr. Wilson, several questions that I'm going to wrap into one. Are there any age limits for surgery, or how does age affect the safety and effectiveness profile of surgery?
That's a great question. So when we talk about the upward limits of age, so in the elderly population, there's not necessarily a chronological age limit, but there is a fitness for surgery evaluation that we do when we look at your medical surgery history. So we want to make sure at whatever age you are safe for surgery, and you'll be able to handle going through the surgery. But we don't necessarily put a limit on it just based on a number. So it's really based on your fitness and the benefit you could obtain from surgery compared to the risk because of age. Now, when we talk about adolescents, there is certainly consideration for youth, and we certainly don't find ourselves doing surgery on young people or children younger than maybe 16 or 15. So there are steps to take to and measures that we try for the pediatric and adolescent population, certainly before surgery. And so we certainly want to wait till the appropriate time, after puberty and things like that. So we don't put hard age limits, especially with adults, but we kind of overall evaluate the safety, the risk, and the benefit, and then we can make recommendations, and we try to keep the procedure choice lowest risk possible.
Thanks. Next question I'll take along. Since this is a lifelong change, how do we stick with your team for years to come, or just for the first year or two? And the answer is we want and prefer that you stick with our team for life. One of the things that we see in the people that over time have some weight recurrence tend to be people that have not followed up with their bariatric program. If you live particularly far away or something along that line, then what we would do after the first period of time, if you request it, is we would transition our recommendations to your primary care physician or some other physician you trust. But I think now with the virtual visits, that almost negates that completely, in which we can see virtually to follow you up over time and make sure you're maintaining your weight loss and monitoring your health issues that are related to this, like vitamin levels, for example. So we prefer that you follow up with us for life as long as you're able to. Dr. Wilson, there's been, even after our other answer, there's been a couple other questions about getting back to work. How do you talk to patients about figuring out when it's right for a particular patient to get back to work? Jamie was off 4 weeks, but how do you address that for a particular person?
Yeah, well, thankfully you have quite a few appointments and opportunities to meet with your providers within the first month of surgery. So, for example, your surgeon visit will be at 7 to 10 days, and again at the 1 month mark after surgery. And really, it's a conversation on how you're feeling, how you're progressing. I've had people to take the full 4 weeks, and I've had individuals go back the very next week after the bypass. They were ready to go, and they were drinking, meeting their liquid goals and protein goals. And so they felt ready. And so it's certainly a conversation. Our office can certainly work with you and your employer with the paperwork that needs to be filled out. We can easily send a return to work note if you go back a little sooner than expected, and answer any questions. So you certainly have a lot of opportunity to meet with your team and assess your progress to determine when you'll go back. But oftentimes I have people going back within 2 to 3 weeks sometimes.
Yeah, and I think most commonly for me, the majority of my patients are back to work at around 2 weeks, mostly because that's what they need to do for their life. Another person had asked, they said, I'm going to remove some of the personal detail. I'm a full-time caregiver for a family member who is essentially totally disabled, or at least needs this person's help in all aspects of their life. How much time would I need to get assistance with that for that sort of heavy lifting? And I think the answer is, depends on how heavy of lifting we're talking about, but generally speaking, somewhere between 2 to 4 weeks before going back to that truly heavy lifting. And that's the kind of thing we'd figure out exactly with when you're meeting with your surgeon, when you're picking which procedure, and figuring out exactly what that lifting entails. But that would be a sort of a round guesstimate. This question's to Ms. Schulz. How does pregnancy post-op affect long-term results? And tell me more about pregnancy after weight loss surgery.
Yeah, so pregnancy is actually more possible after weight loss surgery than before, because part of a woman's return to their best health is increased fertility. So we have many women coming to us who can't become pregnant. They have surgery, they lose weight, and then they can't conceive a child. Having said that, we do recommend 18 months post-surgery until our women attempt to have a child, because it's very difficult for mom and baby to get enough calories during those first 18 months. And post-op then, the weight loss after baby is like any other healthy female would be. We're not seeing people post-op gaining all their weight back because they conceived and had a baby. So should be pretty typical of what you would see. I think most women, as they get older, their metabolism slows down a little bit. So it's not that you aren't going to be working to get those pounds off, but it would be as a normal weight person or a post-op person without the disease of severe obesity. Yeah, that's all I will say about that.
Yeah. So I'm going to wrap several questions in one about specific coverage for different insurances. The answer is I can't tell you off the top of my, and none of us can tell you off the top of our head if your particular insurance covers it or not. That is something that our navigators spend a lot of time figuring out, because when you register with them, the first thing they do is call and have your exact policy to find out. Several people asked about Medicare, and in general, the answer is yes. Same with Blue Cross, which several people asked, but we'll find out for sure when you register and the navigator checks, and they'll also be able to give you a sense of the time frame that your insurance company requires if they do. Karen, another question about self-pay. I'm interested in self-pay, but I think it may be cost prohibitive. Are there financings available, or who could help me answer these questions so I can figure out if that would work for me?
Yeah, if you're a self-pay patient, I would still recommend that you watch the seminar and register. And there's a place on there to put self-pay, and you'll then be put in contact with our financial counselor. They'll tell you, what the options are. I know that Cleveland Clinic does not finance the surgery, but many people will seek their own financing, just like you would for any other important purchase that you would make in your life. So yeah, I think that the financial counselor will give you the absolute best guidance, and also tell you probably to reach out to your employer to see if you can educate them and perhaps have them add it to the policy. We've had some luck in that area.
Great. This is to Dr. Wilson. I've read that after rapid weight loss, I may get gallstones. Is routine gallbladder removal part of these operations?
Oh, no, it's not a routine part of the operation, but we do evaluate your gallbladder. If you have symptoms or several gallstones or abnormal polyps in the gallbladder, we certainly can and do encourage getting your gallbladder removed at the time of your surgery. But routinely, if you don't have any high risk findings on your ultrasound evaluations or symptoms that would point to the gallbladder giving you problems, then we don't remove the gallbladder. There is a risk of you developing gallstones in the gallbladder when you lose weight rapidly. About maybe 7 to 8% of people may need their gallbladder removed within the first 2 to 3 years of surgery, because the rapid weight loss and changes in fat metabolism and some other things may cause stones in the gallbladder that could cause pain and issues necessitating its removal. So if you don't have any stones in the gallbladder, oftentimes we will prescribe a medication for 6 months called ursodiol, and that could help lower your risk of developing gallstones when you're losing weight weight quickly after surgery so that your likelihood of having to have your gallbladder removed is lower within the first few years of surgery.
Thank you. And I'll put it aside. One of the reasons that this question is frequently asked is many years ago, back in the 90s and before, gallbladder surgery was a routine part of these operations because these surgeries were done open. And from a practical perspective, even if only 8% or something around there of patients were getting stones, the surgeons didn't want to go back and remove the gallbladder with all the adhesions that were formed. Now that we do this laparoscopically, that has gone away because it's not such a big deal to go back and remove a gallbladder. And so then that risk calculation for those people that, the 9 out of 10 people that don't need it would get an extra procedure that they didn't really need. So that was part of it's the history that it used to be, but that was many, many years ago. This is a question I'm going to direct back to you, Dr. Wilson. So there's been several questions about particular metabolic conditions, and one of them was neuropathy with diabetes. Does that get better? We showed a lot about the diabetes getting better, but what about, say, for example, neuropathy? Is that something that gets better after weight loss surgery?
I don't know if your neuropathy would completely go away. So some of the nerve damage may not be reversible after surgery. However, we do hear stories of people who have a certain type of neuropathy or nerve pain or different even aches and pains with the joints. If that's caused by the excess weight and how things sit on your nerves and how you move, that may get better. And so I can't say for sure, and maybe Jesse, you could, but I can't say that your neuropathy would completely resolve. But some types of neuropathy, depending on reversibility, may get better.
Yeah, I mean, my understanding, which I'm not a neurologist, but my basic understanding of diabetes-related neuropathy is that there's a irreversible damage, and then there's a component that's related to how well your sugar is controlled. The part that's related to how well your sugar is controlled does get better. Whatever's permanent won't. And so it may sort of turn the clock back a little bit for you, but probably not all the way for that particular one. This is a question to Karen Schulz. I'm interested in weight loss, but I'm not sure if medications or surgery are right for me. How do we evaluate that in a particular patient's case if they are kind of unsure about things and want to figure that out for that particular person?
Okay. Yeah, so if those that aren't sure usually will come into obesity medicine, have a conversation. Perhaps it's a good thing for someone who's unsure and hasn't tried medical weight loss to give that their best try. You always want to make sure that you're mentally prepared and feel like you've given the other therapies a try. Some people may be on the borderline; they're not sure what their BMI is. So coming into medical weight loss would definitely be the first step. You can still take the seminar, still fill out the questionnaire, but in the notes section, put a little note that says medical weight loss only, and we'll direct you to that portion of the program for some education and evaluation.
And on the flip side, there's a patient in here who says, I'm currently in your medical weight loss program, but I think I want to switch over to the surgical side. How do I do that?
Yeah, they can ask their medical weight loss provider, but really important to go to the seminar and register so we can see if you have benefits. I mean, that's the main thing. Not that not having benefits would necessarily mean you couldn't have surgery. The self-pay option is there, but we definitely will want to check benefits. So that's still the next step to go from the medicine to the surgery program.
Okay, I'll take this next one. This person says, Jamie, your weight loss is amazing and you look fantastic. What percentage of people, is this a typical result? What percentage of people attain your level of success? and what are the percentage of patients who regain weight and by how much? So I would say Jamie's result is typical in terms of the percentage weight loss for gastric bypass. So when we look at outcomes, we look at, and you can look at this yourselves, it's been published very widely. You know, there's a certain amount that a typical person will lose, and then there's sort of a high end, low end range. And that's part of the information we share with you at the first visit. So I'd say she's typical in terms of percent. She's probably a better result, quote unquote, better result than many of our patients, because as she had said, and she showed, in fact, maybe I'll even flip back. Well, she had showed those two pictures where she was at a very similar weight, but her body composition had changed a lot. And I think when maybe you can talk a little bit about this more, Jamie, but you incorporated the strength training about 6 or 8 months after surgery. And that's when you really saw not a huge, you did have an increase in your weight loss, and you were still on that weight loss curve we see for about 1.5 to 2 years after gastric bypass. But the transition in your body composition really started once you incorporated that strength training. So, and you talked a little bit about that, but maybe tell people what you do for your strength training.
So really, it's just I have a rower. I have a home. I don't have a gym membership or anything like that, but I have a rower at home that I did purchase after I had surgery because I have kind of some knee issues, and so I really couldn't do anything in terms of cardio that was going to be hard on my knees. So I use a rower, and I do that for about 20 or 30 minutes, 2 to 3 times a week. And then in addition to that, right after that, I have free weights that I actually use more frequently than my rower. Sometimes it's down in our basement. So when I'm down doing laundry or switching loads or things like that, I will do a few reps of the free weights, just making sure I'm exercising my arms and my legs and that kind of a thing. So that's like a little less structured, the free weight kind of thing for me, but it's what works. It's every time I go to the basement, I'm like, I'm going to do something down here and do some free weights, that kind of a thing. And then even it's motivated me more to like stay on that track with exercising. So noticing that you have those changes and that muscle tone, it kind of gives you that motivation to stick with it. So even in downtimes when I'm at work, I actually have a yoga mat in my office, and sometimes if I know I have a little bit of downtime or I know I haven't been doing very good, I will actually do some exercise in my office just to make sure that I'm keeping up with doing that, just because I don't want to lose that tone that I achieved.
Yeah, and this is something that's true, you know, not only for people that have surgical weight loss, but if you do medical weight loss and are successful, the thing that in many studies we found is most important in terms of maintaining that weight loss over time, with or without surgery, is strength training, and a certain amount of exercise will help maintain and prevent weight regain. There's also questions about what are the percentage of people who do regain weight and how much. The answer is it depends on the operation you pick, and that may range anywhere from a risk of about 1 in 6 to a risk of about 1 in 9, depending on the operation. The amount that weight is regained depends on the particular situation. Again, the thing that we're always counseling people to and trying to help you with is establishing essentially an exercise routine, along with the other dietary things that are recommended with your dietitian follows up, to prevent that from happening. But just like any other intervention or therapy, they're not 100% successful. But if you compare people 10 years after surgery versus 10 years after any other treatment for obesity, after almost all the other treatments, the recurrence rate is somewhere in the 90 to 95% range, whereas 1 in 6 is quite low. That's under 20%, and that's probably around where things are for sleeve gastrectomy, with lower rates with the other operations. Another person said, and I'll send this one over to Dr. Wilson. I had the lap band in 2007 and did well, but had to have it removed, unfortunately. Is it possible to get another weight loss operation? And I think several people asked about, wanted me to expand on the revisional surgery. So I think this is a good example, Dr. Wilson, about lap bands, and are people still eligible, or why would people need a revision? And this is a good example.
Yeah, absolutely. Yes, you can certainly you are certainly eligible to get a different weight loss procedure. Even people who come to us with the band still in place, we can do a conversion from the band to a sleeve or a bypass. And so we would certainly evaluate you, do some testing just to see the effects of the band when you had it. Maybe an endoscopy for sure, just to look on the inside, but you could certainly be converted to a different procedure based on, again, your medical history and your prior surgeries other than the band, as well as your weight loss goals and what we think will be safest for you. And certainly sometimes that happens in terms of needing to have things converted to a different procedure, possibly due to not meeting your weight goals or weight regain or complications. You may have symptoms of chronic heartburn or reflux that necessitate you going from a sleeve or having a band to a bypass to take care of that. So you're certainly still a candidate, and we have a pathway through our program to accommodate you and evaluate you.
I answered another question that came through here that was asking also about the lap band and whether, I had mentioned it as one of the services we currently offer, and the answer is we don't currently. It was very effective for some people, but there were a lot of downsides to it relating to having a long-term foreign body in your body. And so that's not one of the options we're currently offering, but also the ones that we currently do are more effective than the band was. I'm going to send this one over to Karen with her obesity medicine hat. I've heard that a lot about some new drugs like Ozempic, but I've also heard they're hard to be approved by insurance. Is this true? And can we tell me more about that?
Sure. Yeah, we do use Ozempic as one of our weight loss medications, as well as some other injectables that are kind of popular right now in the media. If you have type 2 diabetes, we can use those medications generally for weight loss. But if you don't, they're usually not covered by insurance, and they can be astronomical. So like Manjaro, for instance, if very few insurances cover that medication, and it can be between $1,000 and $1,200 a month. So really, taking a look at your individual situation, what your insurance might cover, and then also understanding, as I said before, that medication therapy, on average, depending on which drug, is not going to give most people who are looking at the surgery program that lifetime result. As far as amounts of weight loss are much lower in the medical therapy group. Maybe someday that'll change, but right now, 10 to 15% of total body weight loss is kind of average for the medication therapy.
Yeah, but I'll say it's an exciting time because for the first time, I'd say we've have some medications that are more effective than the ones we've had for the last 20 to 50 years. And so hopefully there'll be more and more as time goes on to help us treat obesity. And then I'm going to have this be the last question. I hope that we got all of them. I tried to wrap several of them in that were similar together. So if I didn't ask the exact wording of yours, I'm sorry. I tried to wrap them all together. I'm going to send this one to Dr. Wilson. What medical tests might be required to get me ready for surgery? I don't have any reflux issues. And that's a good common one.
Yeah. So just to kind of get some baseline information about your overall health, we usually get just a basic chest x-ray, EKG. We do, again, evaluate your gallbladder and liver with a ultrasound of the abdomen and really the right side of your abdomen. Based on your medical evaluation with our providers, you may undergo a sleep study to evaluate for sleep apnea if you haven't been diagnosed, but you seem to be at risk. And then depending on your symptoms or your history, you might undergo, or your surgeon might recommend an endoscopy or EGD to look on the inside of the stomach to evaluate and help us prepare for surgery. But not everyone has to undergo that. You're right, if you don't have reflux, if there's not much of a concern for abnormalities based on your symptoms and your history, we often forego that. And so, but the chest x-ray, EKG, ultrasound of the abdomen, and maybe a sleep study are certainly things that are common. And if we find things that need to be further investigated, we can refer you for additional testing on a case-by-case basis.
Great. Well, with that, I want to be respectful of our panelists' time and the time they set out in their day for everyone. Thank you so much, everybody, for signing on today, for showing up to learn more about weight loss surgery. If you're interested in moving forward, you can go to our clevelandclinicweightloss.com. There's another seminar in there that's different from this one, which gets a little bit more granular into the detail about being a patient with us. There's a registration questionnaire that's quite short. With our then that will get sent over to our navigators to check on your insurance benefits. And with that, if everyone could say thank you, and I hope everybody has a wonderful afternoon.
Thanks, everyone.
Bye. Thank
See you
you.
soon.
Take care.
Bye-bye.